contradictory initiative.
Welcome. Today we're diving into a detailed medical report about Lowell Allen Unruh, who faced serious complications after an ICU stay and multiple surgeries at Methodist Texan Hospital in October 2024. This report is designed to inform regulatory, legal, and medical professionals about his ongoing and future care needs.
Right, Liam. It's a complex case that really shows the multifaceted impact of ICU hospitalization and surgical complications. The report breaks down short-term effects, long-term risks, permanent harm, and worst-case scenarios. We'll unpack these layers to give a clear picture of what patients like Mr. Unruh might face.
Let's start with the short-term effects, the immediate aftermath. One major issue is severe sleep disruption. The report links this to sedative exposure, the ICU environment disrupting normal sleep-wake cycles, and withdrawal from dopaminergic agents.
Just to clarify, dopaminergic agents affect dopamine pathways, which regulate movement and sleep. So, withdrawing these can seriously disrupt the circadian rhythm, causing persistent sleep problems.
And this sleep disruption isn't isolated. It worsens other symptoms like cognitive fog and impaired concentration, which are classic signs of post-ICU syndrome, a mix of cognitive, psychological, and physical impairments after critical illness.
Post-ICU syndrome is getting more attention. Patients often have brain fog, attention issues, and slowed thinking. In Mr. Unruh's case, this is worsened by sedative polypharmacy, meaning multiple sedatives used at once, which can amplify cognitive problems.
Another short-term effect is uncontrolled pain and neuropathy. After multiple surgeries, residual nerve pain, spinal instability, or infection-related discomfort can be quite debilitating.
Psychological distress is significant too. The report notes elevated anxiety, trauma responses, and possible depression. ICU stays can be traumatic, and when you add medication withdrawal and feelings of institutional betrayal, it's a heavy burden.
Institutional betrayal. That's when patients feel let down by the very system meant to care for them, which can worsen mental health.
Nutritional and swallowing challenges are also key. Mr. Unruh had an esophageal perforation, and healing is uncertain. This leads to difficulty eating, swallowing, and risk of aspiration, which can be life-threatening.
Then there's fatigue and physical deconditioning from prolonged immobility. This reduces energy and strength.
And gastrointestinal dysfunction, constipation and gastric motility issues from antibiotics and sedatives. These might seem secondary but can seriously affect quality of life.
What stands out is how interconnected these short-term effects are. Sleep disruption worsens cognitive fog and psychological distress, creating a vicious cycle.
Absolutely. Moving to long-term risks, the report outlines chronic issues that may persist or worsen. Neurological effects from ICU sedation are a big concern. High-dose narcotics and sedative polypharmacy can cause lasting cognitive and psychiatric problems.
The circadian rhythm disorder may become chronic. Dopaminergic disruption can cause persistent restless leg syndrome, insomnia, or disrupted sleep-wake cycles lasting months or years.
For those unfamiliar, restless leg syndrome is a neurological disorder causing uncomfortable leg sensations, often linked to dopamine imbalance. It can severely impact sleep.
Spinal instability or hardware failure is another risk. Mr. Unruh may need future surgeries due to hardware loosening, adjacent segment disease, or recurrent infection.
Psychologically, PTSD or complex trauma responses can develop. ICU-induced coma, disorientation, and perceived neglect can lead to chronic post-traumatic stress symptoms.
Chronic pain syndrome is also possible, with neuropathic or centralized pain from repeated surgeries and nerve damage.
These physical and psychological issues translate into social and occupational limitations. Fatigue and cognitive load impair daily functioning, affecting work and social identity.
There's also the risk of dependency on medications or external care. Some drugs used to stabilize symptoms carry long-term dependency or side effect risks.
Managing these risks requires multidisciplinary care and long-term planning. It's not just treating symptoms, but coordinating across specialties.
Now, the report discusses permanent or irreversible harm. One example is esophageal compromise. Scar tissue or structural weakness could permanently impair swallowing, increase aspiration risk, or cause strictures.
Neuropsychiatric alterations are another concern. Persistent personality or cognitive changes, like memory issues, irritability, or executive dysfunction, are consistent with long-term psychotropic exposure in the ICU.
Functional loss or impairment is also possible, especially if spinal correction is incomplete. This includes loss of physical resilience, stamina, or postural integrity.
The report highlights loss of future medical trust and safety. Trauma from hospitalization can cause patients to avoid care, increasing emergency risks.
And there's legal and financial damage, unrecoverable debt, lost earnings, and permanent shifts in financial planning due to institutional failure.
Lastly, the sleep-wake disorder might have no current cure. If circadian disruption is permanent, lifelong management will be necessary, impacting mood, cognition, and cardiovascular health.
The worst-case scenario analysis paints a sobering picture. Permanent functional disability could prevent independent living or work.
Chronic opioid or sedative dependency could lead to further health complications.
Surgical reintervention, like hardware revision or esophageal repair, carries high morbidity risks.
Severe mental health decompensation is possible, including suicidal ideation or involuntary psychiatric hospitalization.
There is increased risk of sudden cardiovascular events due to sleep apnea, circadian misalignment, and sympathetic nervous system overdrive.
And if self-care can't be maintained, institutionalization becomes a risk.
These worst-case scenarios highlight the critical importance of comprehensive, multidisciplinary follow-up care.
Before we finish, a couple of mental models help make sense of this complexity. First, polypharmacy. The use of multiple medications simultaneously can cause complex interactions and side effects, especially in ICU sedation.
And the circadian rhythm is like the body's internal clock, regulating sleep, hormones, and metabolism. Disrupting it can cascade into multiple health issues.
Also, post-ICU syndrome is increasingly recognized. Surviving critical illness is just the first step. Recovery is often long and complicated.
And importantly, physical, cognitive, and psychological effects are interconnected. They feed into each other, complicating treatment and recovery.
To sum up, Mr. Unruh's case shows the profound and multifaceted impact of ICU hospitalization and surgical complications. Short-term effects are severe and interconnected. Long-term risks are complex and need multidisciplinary management, and permanent harm can deeply affect quality of life.
And the worst-case scenarios remind us that without comprehensive care, outcomes can be devastating. This report is a crucial tool for guiding ongoing care and legal or regulatory review.
Thanks for joining us in this deep dive. We hope this sheds light on the challenges faced by patients like Mr. Unruh and the importance of holistic, long-term care strategies.
Until next time.